Good afternoon, everyone. My name is Gergely Kollányi, and in the next 8 minutes, I will present you my progress of the last 3 months, which focuses on different ERCP-guided interventions in pancreatic disorders. I work as a gastroenterology resident in the Szent Imre Hospital, and my vision is to give patients comfort and the best possible care. I want to achieve that by improving the safety and efficacy of endoscopic procedures. For this, we have two specific goals. The first, in our first project, we are focusing on comparing different tissue sampling methods in pancreatic cancer, and in the second project, we are investigating the efficacy of one specific method for pancreatic fluid collections. The title of our first project is investigating the accuracy and safety of ERCP-guided biliary and pancreatic ductal tissue sampling in pancreatic cancer. Pancreatic cancer is one of the most lethal type of cancers. It is 8th among men and 5th among women in incidence, and its mortality ranks it in the top 5 most lethal cancer types. It is often diagnosed in a late phase when only palliative care is available, so early diagnosis is crucial. Its first presentation is often a biliary stricture or a double duct sign, which is the dilation of both the pancreatic and the biliary duct. In these cases, the ERCP-guided intervention is needed, and during the intervention, brush cytology should be taken according to the guidelines. However, this brush cytology has a low sensitivity taken from the biliary duct. But some studies suggest that taken from the pancreatic duct, this could be increased. So our aim with this study is to enhance the early diagnosis of pancreatic cancer. Our clinical question is that is pancreatic ductal tissue sampling superior to biliary sampling for the diagnosis of pancreatic cancer? We have 3 index tests that we want to compare to each other, and the gold standard is histology in this setting. We want to compare the sensitivities, and also we want to compare complication rates of these tests. Our hypothesis is that detection of pancreatic adenocarcinoma is more effective from the pancreatic than from the bile duct in the case of ERCP-guided tissue sampling. If this proves to be true, then patients may receive the diagnosis faster, and they may need less minimal invasive procedures. Our search key consists of 3 domains. The first refers to the ERCP, the second refers to the tissue sampling methods, and the third refers to the pancreatic malignancy. We conducted the searches in 3 databases, and it yielded over 8,000 hits. You can see on this slide a few of our key articles, which has most of them the same PICO. There are slight differences in the control groups, but they are comparable to each other. As you can see, we are finished with the title and abstract selection, and we have an estimated 500 hits, but we have to resolve the conflicts yet. And after that, we will continue with the full text selection soon. My second project is about investigating the safety and efficacy of transpapillary drainage of pancreatic fluid collections with different indications. As you may know, pancreatic fluid collections are frequent complications of pancreatitis. They are divided into 4 major groups by the revised Atlanta classification. And for our study, 2 of them considered to be the main focus, void of necrosis and pancreatic pseudocysts. Pancreatic pseudocysts can reach up to 40% in chronic pancreatitis, and the majority of them won't resolve spontaneously and can lead to severe complications. In these symptomatic cases, interventions are needed, and there are several options for that. But the guidelines recommend the endoscopic route, which can be US-guided or ERCP-guided intervention, and we want to focus on the ERCP-guided transpapillary drainage. The guidelines have weak recommendations for its indication. They are not crystal clear, and they are supported by really low quality of evidence. They have a high success rate, but they are underutilized compared to transpapillary drainage, although they have additional benefits too. So with this study, our aim is to understand in which cases should we do the TPDs. Our clinical question is, what is the safety and efficacy of TPDs in these cases with different indications? These different indications include different type of PFCs, duct disruptions, localizations, size, acute or chronic pancreatitis. If our hypothesis, which is there are conditions in which TPDs are safer and more effective, proves to be true, then our patients may receive safer and more effective care by improving the understanding of the correct indications. This is the search key we conducted our preliminary searches with, and it yielded over 200 hits. You can see some of our key articles, which has the exact same outcomes, but they are all retrospective studies, which is a limitation of our study. So summarizing, we have two projects we are working on. The first is about comparing different tissue sampling methods in the presence of pancreatic cancer. And the second is about investigating the transpapillary drainage for the intervention of pancreatic fluid collections. And I want to thank you for your attention with this quote from Sir William Osler. He who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to sea at all.
Congratulations, it was a great presentation. I'm just wondering about your second topic. So what is the optimal timing of the endoscopic intervention in those fluid collections?
The optimal time?
Yes.
We are focusing on two of the pancreatic fluid collections, which are walled-off necrosis and pancreatic pseudocysts. And the optimal time is after 4 weeks, but it can differ from that because this 4 weeks is based on the encapsulation of the fluid collection. So when this happened, it is optimal.
Thank you.
Thank you for your question.
Can you please explain to me what exactly the transpapillary drainage means? You just put a stent in there through the papilla into the fluid collection?
Exactly. With the ERCP, the cannulation of the papilla happens, and then through the papilla, a stent is placed into the pancreatic duct, and this can bridge a disruption of the duct and can reach to the fluid collection as well.
I have a question about your first project. You mentioned that you want to compare the complications. So I was wondering if the pancreatic duct brushing doesn't cause more post-ERCP pancreatitis.
Yes, thank you very much. It can cause, the post-ERCP pancreatitis, which is a frequent complication of ERCP, or the ductal manipulation, can be increased in brushing, but the different articles we found report different percentages of these complications. So that is why we include this outcome too, that we want to look for.
Okay, thank you.
You have a patient which has an antral pad sign, okay? It is related to your first presentation. Would you still go ahead and do the brush biopsy?
Sorry, what kind of
Antral
sign?
pad sign. Do you know what it is? Antral pad sign.
Antral?
Antral. Antrum. Jomor antrum.
Antrum.
Yeah.
Yes.
Antrum pad sign. Do you know what it is?
Sorry,
No, it's okay then. We'll discuss it later.
Okay.